Well, good morning all, and welcome back to our meeting on priorities on the health horizon. I'm Michael McGinnis from the National Academy of Medicine, and on behalf of the National Academy of Medicine component of this partnership, it's my pleasure to welcome you all back and to start off with a warm note of thanks to each of you who have joined us for this important set of conversations. For each of you who were here with us yesterday, and especially, of course, to our speakers and panelists and participants who provided us with an extraordinary program yesterday that sets up today's activities beautifully and ensures that we're going to have a series of conversations that are both well-informed, and if the spirit of yesterday's conversations extends, they'll be inspired as well. We're going to hear from our program chair, Dr. Neil Poe, in just a couple of minutes, who will provide a summary of yesterday's conversation, a recap, and a charge for today's work. And I'll just point out one thing. And that is that the meeting started out yesterday with an extraordinary first speaker and was followed by extraordinary second, third, and fourth speakers. But one of the things that our first speaker referenced was a quote from the late Toni Morrison, who's a graduate of Howard University here in the district. The quote went something along the following line, and that is that our charge is not to do things differently, but to do different things. And it's a wonderful axiom for us to bear in mind, in particular when we're talking about the work of PCORI, because PCORI was born out of the spirit of doing different things, putting patients and populations at the center, and ensuring that we, as we undertook the various aspects of not only generating research, but applying the discoveries that are product of the research process, real time into practice, and setting the stage for a transformation, not only in the way we discover and generate new knowledge, but in the way we accelerate the continuous learning process. That was a theme that was re-emphasized throughout the day's session and will extend throughout, I'm sure, throughout today's conversation. So thank you again to everyone, and let me turn the podium over to Dr. Nikayla Cook, the head of the Patient-Centered Outcomes Research Institute and our partner.
Thank you so much, Dr. McGinnis. And I want to also thank all of you for the robust discussions and insights that were generated from yesterday's overview presentations, the reactor panels, and some of the discussion. And really a heartfelt thanks to the participants, the presenters, the reactors, and the facilitators for today as well. I'm really looking forward to the discussions today. As I mentioned yesterday, PCORI is an organization that's governed by our healthcare stakeholders, and our name, our legislative mandate, and our board's vision have really combined to make PCORI a stakeholder-driven research institute. And as Dr. McGinnis said, one of the ways in which PCORI does different things is with a strong focus on engagement. And we operationalize engagement in research in every stage of the research process, including in the development of our research priorities. And that's why these sessions are so critical to us and for our strategic planning process to inform our national priorities for health and our research agenda for the future. And so your participation today and yesterday is a significant part of our approach to gather diverse perspectives and ensure that our work is responsive to the priorities and the needs of patients and other stakeholders as PCORI plans for its future. And we want to hear all of your perspectives to achieve that diverse set of inputs with regard to the topics that we have teed up for discussion today. And several of my senior colleagues at PCORI will be joining the breakout sessions to listen into the dynamic discussions today. And unfortunately, due to some scheduling challenges, the PCORI's Board of Governors meeting overlaps slightly with today's agenda. Thus, I'll miss the closing sessions today. But I wanted to ensure you that Dr. Sharon Levine, Vice Chairperson of the PCORI Board of Governors, will remain with you throughout the full session today. And I'll look forward to hearing the day's discussions following the meeting. So thank you all once again for participating and lending your insights into this really important process for us. We couldn't be happier with the discussions and the robust insights and input that we garnered from yesterday and know that they'll carry through today. So thank you. And with that, I'll turn it back to Dr. Poe, our sessions facilitator and chair.
So welcome everybody to day 2 and hello from San Francisco. I want to remind people that the purpose of this meeting is to engage in blue sky thinking that can help inform PCORI's priorities for health as it embarks on the next decade of patient-centered comparative effectiveness research. So for the benefit of those who were not unable to join us yesterday, I'm going to spend a few minutes distilling some of the key themes that were discussed, a recap of yesterday. So yesterday, the meeting was designed to prime us and set the stage by reviewing 4 macro topics that shape health and healthcare. So Rachel Hardiman started us off talking about social environmental factors, including social determinants of health, access to care, particularly structural racism, and the legacy forces and policies that have reinforced health disparities in the country for more than 400 years. Joshua Denny then led us in a conversation about technologies, a big topic that encapsulates and undergirds so much of how we live, how we work and play, and how we engage in our health and healthcare. And he showed the aspiration of precision medicine at scale is the embodiment of leveraging technology. And we heard about how this is progressing in the All of Us research program led at the NIH. And then David Mulstein talked about the important area of value optimization, critically examining the structure, financing, and organization of healthcare, and identifying ways to deliver better value, which means different things, of course, to different stakeholders. This entailed a thoughtful look at current payment models, policy changes, and delivery models that are in place today. And finally, Renu Kaushal talked to us about infrastructure, comprised of the people who provide and receive care, real-world data generation, health systems, and the cycle of generating and using evidence in the context of a learning health system. The importance of a sustainable research infrastructure that can support continuous learning was also driven home. Each speaker reflected on the way research has illuminated how far we've come, for example, in precision medicine, but also how far we have to go. We are a long way from precision prevention and precision health, as it was pointed out yesterday. So speakers described the need for health system transformation, as Dr. McGinnis said, doing different things, not doing the same thing differently. And that included how we educate the workforce on racism, how we better enable the use of evidence at the point of care, and how we transform a system that begins with patient strengths as the centerpiece or cornerstone of healthcare. They also spoke about research transformation and policy transformation. In the research transformation space, both Dr. Denny and Dr. Kaushal described the fundamental importance of co-designing research with patients, as well as returning research results and supporting the research of others. This would be a remarkable shift if it were widespread across the research ecosystem. Additionally, the interdependence of these four macro topics was evident throughout the presentation. We heard essential remarks from all four speakers about how structural racism shows up in both explicit and implicit ways in health and healthcare, and the fundamental need to do things differently. After the four compelling presentations, which will be shared with all of you in the days ahead, we heard from a panel of 5 outstanding reactors who represent diverse stakeholders. Among their tremendous insights, a few stood out. They said, stay focused on the need to drive better health, not simply better health care. At present, we are building on a broken chassis, and if a chain is only as strong as its weakest link, we need constant, systemic work to drive our efforts, and reduce inequities, address value, and assure a stable, technologically forward infrastructure. Are we in pursuit of incremental improvements that can yield a better system, or a full-fledged reimagination of a health system? As we all know, the COVID-19 pandemic demonstrated how quickly healthcare can pivot when it is really imperative, and determining which changes to retain, such as telehealth, and at least steady while they're in process. This is a huge opportunity. To really affect change, we have to get uncomfortable. This is largely with relation to dismantling racism and other isms as well, but it also pertains to optimizing value. Getting uncomfortable also means there will be a power shift. So we learned to continue to learn every day. If we're not listening, we're not learning, and learning must occur to make a change. So we have to combine our assets and combine our approaches, take down silos, and approach health and healthcare as our collective moral imperative and encourage shared learning. So with that, let's get on to day 2. What we are going to have today is breakout groups that will discuss trends, opportunities, and priorities that build on the themes that we laid out yesterday. So I'm going to introduce our speakers today, not our speakers, our facilitators, excuse me, who will facilitate each of the breakout groups. The first on technologies will be facilitated by Dr. Julia Adler-Milstein, who is director of the Center for Clinical Informatics and Improvement Research and a professor of medicine here at the University of California, San Francisco. The second breakout group will be on the social and environmental factors, led by Dr. Carolyn Fichtenberg, who is managing director of the Social Interventions Research and Evaluation Network and Research Science in the Department of Family and Community Medicine, also at UCSF. Third breakout group will be on optimizing value, led by Dr. Eric Larson, who is senior investigator and former executive director of Kaiser Permanente Washington Health Research Institute. And finally, our fourth group will be on infrastructure, led by Dr. Risa Lovizo-Mori, the Robert Wood Johnson Foundation Population Health and Health Equity Professor Emerita at the University of Pennsylvania and former CEO of the Robert Wood Johnson Foundation. So a few logistics to get us started. In the sessions, we ask that speakers turn their video on when speaking, and otherwise to keep muted, even in the breakout rooms. This will help to improve audio quality. To the public, the breakout rooms will not be viewable, but the sessions, along with other portions of the meeting, will be recorded and shared in the days that follow. At 12:45 Eastern Time today, the meeting will then reopen to the public so that the public can, and all of us can hear breakout group reports and the concluding discussions. Some guiding questions for our breakout group include the following. Thinking about the 4 topics presented on day 1, are there additional top concepts or topics to consider? What are the potential disruptors and opportunities and key trends on the horizon for your topic area? What are the major obstacles or challenges to advancing progress related to your topic? And what else would it take for this topic to have a measurable and positive impact on health and healthcare in the next 5 years? I want to remind people to remain in that blue sky thinking mindset about key trends in emergent areas that lend themselves to the optimization and transformation of health and health care. So with that, we will break out and we will reconvene for our plenary session at 12:45 Eastern Time. Presentations adding more richness. And now this morning we had our breakout groups that went into more, hopefully went into more detailed discussions. And I trust those conversations were clairvoyant, rich, and encompassing. So I want to thank our facilitators and the breakout group participants for engaging. How we're going to organize this is we're going to have some reporters who will report out from the groups. I want to remind the audience members that they can submit comments through the chat function that is located in the controls at the bottom of your Zoom screen. And we'll capture these for the record, although we won't be able to address them in real time, given the size of the audience and limited time for interactions. But those comments will be taken very seriously by PCORI. I think we ought to get on with hearing our reporters and the hopefully more exciting ideas that came out of the work groups. So I'm going to invite our first reporter on the infrastructure.
Toggling here, so we had a small but mighty discussion group, and you should be able to see we have just a quick 4 slides to share with you. As you all remember, this was the discussion about infrastructure, and in our group, we talked through several really interesting aspects. In terms of other topics to consider in the realm of the infrastructure, we talked about leveraging what was created as a result of the COVID-19 pandemic. We know that there were silver linings, which is a term Esther Krofa from Faster Cures used. There were tremendous administrative and contracting efficiencies that were developed throughout the research process, and we'd love to be able to see if we can continue to retain that apparatus and expand it as we continue down the path of doing research. In this realm, we also spoke about the many learning networks, the research networks that have sprung up from the FDA's Evidence Accelerator to the CTSA's N3C, National COVID Cohort Collaborative, and how all of those really have served as almost a forcing function to help people who, reimagine how they work together in a way that really did, serve the entire research community very productively. And we also talked about the fact that this virtual world we are now in also changed how we work together. A second big aspect that we thought needs to be on the table is around communication, translation, and the diffusion of evidence in a sustainable way, and the ability to reach broader audiences, especially for research that's policy relevant, but not exclusively that research, but certainly, how do we do a better job of translating our research for the general public? We had a brief discussion in our group about the role of health literacy, including scientific and data literacy, and the importance of understanding how people use information. I think we've seen throughout the last year plus that people have very different approaches to receiving information, processing it, and using it to make decisions, whether those decisions are related to vaccine choices or adhering to public health protocols. So that was a really important thing that I think that needs to be considered in the broad mantle of infrastructure. And then in terms of the challenges and disruptors on the horizon, we really took heart, I think, at the way that data systems and networks have been linked together to support discovery. And that taken as a whole, this represents a collective disruption opportunity as we figure out how to learn from new data sources, as we look to the experience of the UK recovery trial for COVID, and that we saw really vital new ways to share and link data and leverage our research networks, which helps us ask better research questions. And then also related to that is the ability to aggregate data. And again, in the vein of getting groups that might normally be competing, getting them to cooperate. That was a significant positive disruptor that we think has some important future potential. A second thing we discussed is the combination of new sources of real-world data, and I apologize for the acronym, but real-world data and telemedicine. We have many, many new sources of understanding a person's whole health experience. A clinician being able to look into a patient's home in a virtual visit gives them a new way to understand that person's health and social needs. So we saw that as a disruptor and a way of really thinking differently about how we use real-world data. We have patient-reported outcomes, we have person-generated health data, and what we need now is a way to link, curate, ensure the quality, and prepare that data for population health and for health research. Next, we spoke about the obstacles to advancing progress. We came back frequently to the representation of the data, and this certainly came up quite a bit yesterday in the plenary presentations. Who is represented in the data? How are the data used? And what implicit biases might be present? So really being very attuned to that as we go forward. A corollary to this, interestingly, was the access to the data itself. Is it equitable? We talked a bit about proprietary data and use by both private and public entities, and the importance of ensuring a level playing field with regard to data access and data use. So we think that's a challenge that warrants a lot more attention. We had a fascinating discussion that really could have taken on a head of steam on its own, related to the complexity of health and healthcare. And our colleagues from Community Catalyst talked about how just understanding what people go through to navigate the healthcare system creates incredible fatigue and tremendous burden, frankly. And so it might be something that impedes people from wanting to think more about health and healthcare. And our colleague, Dr. Fracht, noted that there is work being done to look at the administrative burden of navigating the health system from the patient's or the person's point of view. I think that will really be an interesting splashy paper, frankly, when it comes out. Because we all know that there's a cognitive burden, there's opportunity cost, and of course there's time burden in navigating healthcare. And then the last point we had on this in terms of the challenges, we saw that the evidence to practice loop can really be tightened and reduced as a result of what we've experienced during the pandemic. But there was some concern that we could slip back into quote unquote the old ways of doing things and lose the gains that we made in terms of timelines and other aspects of infrastructure. And then finally, we talked about what it will take to have a measurable and positive impact on health and healthcare. Most importantly, we circled around the need to have a roadmap. We need clarity about where we're going, what is the destination, and what is the vision for a robust infrastructure for health and healthcare? How does it encompass public health? How does it encompass healthcare systems? And what do we do to ensure that vision? It was noted that will help both the advocacy community, it will help in terms of policy, it will help in terms of research, and certainly it will help people as they engage in their health and healthcare. And we thought that PCORI could potentially play a role here and bring some attention to this. So it was a great discussion. All thanks to Risa Labiza-Mori for serving as a wonderful facilitator, and I'll turn it back to her in case there's other things I've overlooked.
Great, thanks, Sarah. I think you did an incredible job of summarizing a conversation where this last bullet really describes where we came out, that in the last year in particular, we have seen a lot of different things to do. And if we can learn from them and sustain those that are positive, there's a real potential to have measurable and positive impact on health and healthcare through infrastructure. So thanks to the whole group, and I'll turn it back to you.
Hey, well, thank you, Sarah and Risa. Really exciting things and some important challenges. So let's go next to our technology work group report, and we'll have Dr. Kathleen Blake.
Thank you, and thanks, of course, to our moderator, Dr. Julia Adler-Milstein, and also to our entire group. We had, as others did, a robust discussion and started additional topics, concepts to consider, and spent quite a bit of time talking about really ensuring that there is trust in the system, that the solutions that we come up with from a technology standpoint are equitable, that broadband access be, I will use the word universal, and we spoke about it as similar to some of the rural electrification projects, the accessibility to water, potable water, and then the really reimagining how infrastructure could change. And again, a lesson from the pandemic that a lot of care can be delivered at home and does not have to take place in the walls of a facility. The opportunity for PCORI is to be able to examine hybrid models of care so that we optimize the location to meet the needs of the individual person. We recognize that technology resonates differently with different individuals. And so that assessment of where they are and what it is that an individual person wants, so that they're at the center of choosing their health care, but also the modality is important. We saw the use of technology as giving us some real opportunities to generate evidence that we previously would not have considered. And we're already seeing some of this, but we think it merits ongoing research to see what's really valuable. And then generating evidence in practice and in a bi-directional way so that those who are generating evidence are receiving the output from that evidence. And so the generator might be the person about whom health data is transmitted. It could be the clinician, but that bidirectionality we think could be supported by technology. Next slide. So in terms of potential challenges, disruptors, opportunities, key trends, we felt that there's lack of an open system that really empowers patients, not just allows, but empowers them to be at the center of the research. Second bullet point, time is a non-renewable resource. And we had some discussion about that challenge in terms of the engagement of individual clinicians, providers, but also the time that is spent by investigators, writing grants, writing the reports of grants, and how much is the real work versus those pieces at the beginning and at the end. And then spoke about the disconnect between systems, that we can always see improvement with respect to people concerned about quality, though we all should be, researchers, public health, and health systems. And speaking back to the last presentation, realizing that all of these, shall we say, siloed stakeholders have had to work very closely together through COVID. In terms of the opportunities, we think that technology used ethically, properly, will give us an opportunity to make inferences about people's lives. However, they need to know that those inferences are being made and that their privacy and security will be protected. And then this notion of revisiting existing regulations, because as we talked about the incentives, we very naturally came to talk about accreditation or requirements to be able to continue to practice in a given facility, for example, but realized that could impose more burden. So the bargain would be, are there existing regulations that can be sunsetted, removed, and that would allow for some creativity in terms of the alignment across agencies. Next slide. In terms of obstacles or challenges, and this is really an extension of the prior last bullet point, any new requirements that are placed on clinicians will result in resistance, or if they don't, could really run the risk of becoming check the box sorts of activities. And so PCORI could help with this by conducting research that truly measures if burden is being reduced and how quickly. We had a robust discussion about community needs assessments as maybe being an underutilized source of information, particularly with respect to the community needs assessments for technology, whether it be the actual hardware and software, or whether it be the technology literacy, or whether it be the rules and regulations that foster its use. And that the community needs assessments, there was a general sense that they are so variable, and the actions that result from those needs assessments are so variable that we're not persuaded that we're getting the full value of that tax benefit to the not-for-profit organizations. There was discussion also about maybe even at the state level, having patient and caregiver engagement opportunities so that they are regularly at the table, and that some spoke about hesitancy in their environments because of the cost, and said sometimes what then happens is you rely on the perspectives of staff and particularly of health systems, and that it's not the people themselves who dictate the agenda. An important area that was also raised had to do with being able to accurately represent the context in which the individuals are living, receiving their health care, experiencing their health, and needing the data structures to be able to accurately describe it. And then some discussion about using context and data quality to address some of the issues related to implicit bias in the data as we currently collect and use it. Next slide. Then what else will it take to be able to have a measurable positive impact? Not surprisingly, we talked about the need, even though so much work has been done already by PCORI and others, we just need more perspectives of patients, people about their health and healthcare. And specifically, given the experience with telehealth, we need to talk to these individuals. How is it going? How well is it working? What are the obstacles? Because I think we might learn some things that surprise us. The experience with open notes is soon, and that's really the brand name, but what is the experience of having open access to one's electronic health records and the experience using digital tools and wearables? There was interest in the role that unique technologies, new technologies can give us new sources of data. And how do we weave that in to existing sources and how it might make research more efficient? We wanted to know about specific assessments so that we could understand, again, that context, those circumstances in which the data is collected. There was a recognition, because again, time is the non-renewable resource, that we need proven ways to strengthen the connection between the academy and health systems, or really those in the, we might say, front lines. And then interest in developing partnerships with large technology organizations, engage them as research partners with the academy, with the health systems, with patients, to be able to test our hypotheses at scale and to be able to advance health more rapidly. So I'll stop there and ask if any of the other members of our group want to add to these comments.
I don't know if Dr. Adler-Milstein would like to make a few comments.
No, you did a great job. I just was noting that I was here, and that was an excellent summary.
Okay. Well, we'll have a little time for discussion after this that people will be able to chime in. But let's then move to our next group, which is next report, which is on social and environmental factors. And Dr. Ivory Clark will present.
Great, thank you so much. As the other two presenters have said, we had a very rich discussion, particularly around the social and environmental factors. And so in thinking about other additional topics and concepts that to be considered, the group really honed in on acknowledging that the social and environmental factors, they're strongly linked to health equity and the idea of just health, so health justice. And the notion that this was really important in understanding the notion that people have equal, equitable, and and the opportunity to thrive and be healthy as well. And so when we were considering additional social and environmental factors, that's things like education, so early childhood education, language and literacy, but also things such as social cohesiveness, environmental racism, and then linking back to redlining. And importantly, one of the things that arose in the conversation, particularly about redlining, is we tend to typically think of that in the housing sector, but really that has a translation to redlining in health as well. And so we continued the discussion in looking at how social and environmental factors are not things that are unique or solely the responsibility of the healthcare sector. And this is something that was raised in our conversation yesterday as well. There are things that the healthcare sector can do internally, but there's also a role and a responsibility for the healthcare sector to effectively partner externally with those that also have a role and influence in health, in the health of patients. And then finally, as we know, PCORI is centered on patients. And so patient-centeredness really embodies this critical look at social and environmental factors. We know that people's lives are not compartmentalized. You don't experience social needs in one silo and then health in others. So the whole life of the individual really must be taken into account and thought about. And another part of that discussion was looking at, focusing on what patients and families want for their health. It's not just what the health outcome is, but it's what do you want your health for? What are the things, understanding what are the things that matter to them and what's going on in their lives are some of the ways that the social and environmental factors can be pulled into getting to this just health state. Next slide, please. And looking at the potential challenges, disruptors, opportunities, and key trends that are on the horizon, evidence appeared here. So there's really excitement around looking at the social determinants of health, exploring the social and environmental factors now. But without evidence of impacts of interventions, people can maybe investing in interventions that are less effective. And we know that that leads to a potential risk that without evidence of effective impact further down the line, looking at the social and environmental factors may not remain sustained over time. And so this also flows into the durability of cross-sectoral interests. As I said, there's strong interest now, but it's critical that if we're exploring social and environmental factors within the healthcare system, but also externally, it's critical that we retain this interest over time across the multiple sectors that influences one's health. And then finally, we spoke a bit about also considering the needs of the support systems for patients, so particularly their caregivers, and especially when you think about the chronic conditions that some patients face and how social and environmental factors play a role, not just for the patient, but also for the support system of our patients. Next slide, please. And looking at the major obstacles and challenges, data appeared here again. And so in particularly, it's the recognition of how we can be performing research that will inform practitioners about what they should be doing, but also quite critically here was what they should not be doing. And that's a significant component of this research and evidence sphere when we talk about the social and environmental factors. And a second potential roadblock is the conflation between goals and tactics. So we had a bit of conversation around ensuring that we're clear in understanding what our overall goal is and what's a tactic. So on the slide, we discussed how diversity is great, but it's not a goal. It's a tactic to get us to an organization's goal. And so when we think about the social and environmental factors, we do need to be clear that they are tactics. Addressing social and environmental factors are tactics in helping us to get to our goal of just health. And so that's the goal of getting to health justice for our patients. And next slide, please. And finally, as previously discussed, the importance of collaboration and partnership is really what's going to help lead to a measurable and positive impact on healthcare. So again, recognizing that we're talking about this from a healthcare systems perspective, but there are true components related to collaboration and partnership in providing services, particularly in those that address the social determinants of health. We also discussed how PCORI has the ability to think about cost. And it's not just the cost of clinical care, but there's really a component here of thinking about opportunity costs, the cost of lives, as well as those of out-of-pocket costs. So when we think about partnerships and who are stakeholders in the conversations around social and environmental factors, that again, we go back to that understanding of what are the broad networks of players. And so PCORI has the opportunity and the ability to think about costs as it relates to the various partners and stakeholders and looking at overall health. So we had a large conversation around employers, and that's where that opportunity cost comes in. And then finally, the need to deeply engage with all stakeholders and understanding their needs is another way to have measurable and positive impact on health and healthcare. And Dr. Cook has already emphasized PCORI's strength in engagement and leading with engagement. And we saw that as a true priority in our group, in our conversation around moving forward and addressing the social and environmental factors. So I'll pause there and ask if anyone from any of my colleagues want to add to that brief highlight.
You did a great job, Dr. Clark, in summarizing our conversation. I think the one thing that I might just lift up from this, echoing back the idea of not just doing things differently, but doing different things. This is really one of the areas that I think is most different for the healthcare sector. It is this new territory where there are a lot of questions about the appropriate role for healthcare and the right way to engage. And so I think, we did have a fair number of kind of blue sky thoughts around things that PCORI could think about doing differently, including things around, maybe some of the, I think as highlighted in this first bullet, that, so much of what affects health is done by organizations that are not healthcare organizations. And where does that fit in with PCORI's work? Is there a room to expand there to think about studying comparative effectiveness of non-healthcare interventions, but that have definite health impacts? So I think that was one of the areas that we pondered and I think is worth highlighting. Anybody else from our group want to add anything?
Okay, well, thank you, Dr. Clark and Dr. Fichtenberg. As I said, we'll have some space for more conversation. So let's go to our fourth group on optimizing value. And I believe Dr. Erin Hove will present for us.
Thanks so much, Dr. Poe, and really have appreciated all of the report outs. This has been a great set of presentations and really looking forward to the discussion. And I think what I'd like to start with as we talk about our breakout group is really emphasizing how much our group discussed the complete paradigm shift that we're really talking about in terms of optimizing value. This is also a big change for PCORI as a whole to really be able to address these issues squarely as part of their remit, and a very, very exciting development from our collective perspective. So a lot of what we talked about really was what the components of value are that actually matter to patients, that matter to citizens. And so you can see here that we really wanted to make sure that was front and center and the topics to consider and discuss. which is how we then turn that concept of value into workable measures, and then make sure that we have the data to advance these measures to fuel this paradigm shift and journey that we're talking about. And in fact, this is where a lot of the feedback from the infrastructure and technology groups, as well as the community and social factors group, I think really come into play and align very nicely with our discussion. In addition, we talked about just how much innovation is happening, certainly a focus on the pandemic, and I'll talk more about that on the next slide, but just making sure that we leverage understanding, and that PCORI and the national academies can leverage an understanding and identification of best practices to understand this value concept, and then making sure there's a particular focus on alignment with spending and impacts on individuals and communities. And I think actually, Mike, I'm just realizing I want to just make sure that I've got the right slide deck. So I'll just turn that question to the NAM folks. The last one that I just wanted to address was really a lot of discussion about alignment and integration with the public health system. And then also, again, acknowledge, and this is particularly important to me, I'm the innovation director for DC's Medicaid program, that we, again, pick up on Dr. Siegel's theme from yesterday, and ensure that we are addressing the needs of our public insurance system and making sure to address some of the key needs for those providers and patients as part of that transition. So the next slide, we really want to talk about, again, these potential challenges, disruptors, and key opportunities. The concept of never wasting a crisis or seeing the opportunity in the crisis, as many others have commented on, is it was really important to us. And so we particularly highlighted a couple of different issues with respect to especially the definition or the concept of health being the desired attribute of each individual, and addressing the need to address whole health, as I think many others have mentioned. The need to really, as we've seen throughout the pandemic, understand and appreciate patient heterogeneity. And we've obviously seen that through the public health emergency with respect to individuals' interactions and experience of pathogens, as well as treatments, and the need to move towards that precision medicine and precision treatment concept we've discussed. And then we also talked about making sure that there's the kind of provider resilience angle on this discussion of value. The pandemic, I think, has created some new ways of thinking for providers about the kinds of payment models and how they achieve value for themselves, for their patients, and to really make sure that we're engaging providers, quite a broad array of heterogeneous providers in the ways that they think about those issues, so that we can really find the right models that work both for patients, providers, and communities. So I'll just move on to, we also did talk about, again, engaging patients as partners, and, the ways that we've seen individuals really engage more in masking, social distancing, self-care, and understanding what's working there. And then we did also have a conversation about being very frank about how PCORI will implement the mandate to study economic impact, and focusing more on concepts such as financial toxicity, right? What is the impact of cost and achieving value on patients and families, rather than necessarily focusing so much on price, which could be more of a distraction from this value concept. Next slide, please. So some major obstacles or challenges to advancing progress. Clearly, we'd be remiss if we didn't acknowledge, as Dr. Molstein showed in some of his slides, the strong economic dependence on health and healthcare. And again, we talked about if every system is optimized to achieve the results that it gets, our paradigm, if we're really shifting it, may need to lead to a question about how does your organization fail on generating widgets of healthcare or units of healthcare to the extent that success means profit instead of health. So really, again, flipping the narrative and talking about what organizations need to do to get to a different type of success. And that, of course, requires some understanding of how the legacy chassis can be obscuring where investments need to go and really rethinking those issues. And then also, obviously, the way that social determinants factor into that broader definition of the system, that they're drivers, they're not just external factors. So we also talked a great deal about preservation of health versus the pursuit of health. And again, that needs to be part of a value discussion. In this context and some of the others, we talked a lot, as some other discussants and commentators yesterday talked about, the need to focus on patient-reported outcomes and really engaging sort of a broader holistic sense of how to ask those questions, not just about preserving mobility, for example, but really thinking about health in all aspects. And then acknowledging that this transformation that we're talking about will create winners and losers. But of course, there are winners and losers now. So how do we have that dialogue, and how does PCORI and the national academies, similar to the way that they've done with reframing the focus on patients and patient-centered outcomes research, how do they help so set the stage for a different conversation about what we're trying to achieve with respect to value? And last slide, please. So, the question of what else it will take to have a measurable and positive impact on healthcare. Again, this concept we've talked about a bit today, starting with health versus cost. Again, that value proposition around health and defining it clearly is a transformative opportunity to change the narrative away from self-interest and towards more of a common good. As we noted on the last slide, that's not going to be easy. We acknowledge that, but it's really an essential part of this work. And then, the concept of seeing actually the fact that we haven't yet fully defined value in our health system as a public health emergency, right? That we actively know how much the choices that we're making as individuals and societies is impacting our communities, and that in order to really make sure that distribution of those resources is going to where we need them to achieve health, we really need to sort of rethink that concept of value. And as part of that, what are the business models that can help providers and practices transition to be part of this, right? And individuals and communities. So we talked about sort of a matrix framework that would really address what the burdens and values of healthcare are for individuals and communities, and really trying to encourage PCORI to think about how to develop a diversified portfolio across that matrix of research questions that will help us understand the value proposition and burdens, again, at that individual and community level. So Dr. Larson, Eric, do you have anything that you would like to add?
No, thanks, Erin. That was a great summary. And thanks also to Mike and the group. Just, two highlights that struck me is the opportunity that COVID has presented in really turning healthcare in very different ways. And then the opportunity that PCORI has in its new authorization language. And I think our group was really excited about what PCORI has ahead of it as a very, even more influential organization. But thanks to the group, and thanks, Erin.
So thank you, Dr. Holman and Dr. Larson. That was wonderful. So it looks as if we had some really vigorous discussion and new ideas put on the table. I love some of these, value as a public health emergency, the issue of how we sustain cross-sectional interest, how we make technology that empowers patients rather than just technology for the sake of technology. And then in our infrastructure, the role of having systems that disseminate our information and promote uptake. So lots of really great ideas there. Let me open it up to our participants to see if they would like to expound on some of the things that discussions that went on in the work groups. And you can raise your hand and I will invite you to speak. You couldn't have said it all, so. So Kathleen Blake.
Sure, I was holding back because, but not seeing anybody else raising their hand. I think one of the real challenges with the value discussion will be that, and we did talk some about this in our work group, I raised the issue, is that there are so many different stakeholders that they will always be looking to their right or to their left for somebody else to give up what it might be the revenue or the opportunity that would then be redistributed to someone else. So I think it would be helpful for PCORI to really do a deep dive into that whole process, now that it can, of the transactional nature of that discussion. Because I think that, for example, for a clinician, they might say, I will make a trade so long as there is a commitment that I will work fewer hours, that it won't be 7 a.m. until 9 p.m. at night, that the time saved with the technologies will not just be reallocated so that I go from seeing 28, 30 patients a day to 40. So I think it will be those kinds of honest conversations. And I'm sure with other stakeholders, there will be an equal sense of what they would trade so that the financial picture is more favorable.
Interesting concept is promoting healthy transactions to overcome our differences or our uncomfortableness to move to doing different things. Interesting. Would others like to offer comments? We have a quiet group here. Okay, May Gaines.
Bruce, this discussion was, sorry, I'll turn on my video. Starting to make me think about resources that we may have lost that we could regain. The point that was just made me think of that. That I think there's a fallow laying mine of energy that could come from healthcare professionals and patients getting returned to a kind of relationship that would be a form of remuneration again, like it maybe has been in times past when time was less pressed and healthcare was less kind of mechanized and delivered as opposed to co-created. maybe I'm looking a bit backwards and a bit halcyon, through rose-colored glasses. But I do think there was a time when that relationship was one of the things that really compensated clinicians of all kinds. And it strikes me this in many of these areas, but the one in particular was the use of technology. Obviously, not just to facilitate billing and not even just to facilitate health research, but rather to facilitate communication. And I think you called on us to really think about yesterday, to really think about, Bruce called on us yesterday to really think about telehealth. And I think that's one way, one thing in technology, but there are lots of other ways. If we look at Scandinavian countries and what they're doing with chronically seriously ill patients and how they can report in daily and how it reduces visits, but increases knowledge and increases feelings of safety and well-being and even increases health because they're not afraid that they can't get in touch with their doctor and blah, blah, blah. So it just all brings me back. I realize it's too wordy because I'm sort of thinking as I'm talking, but it brings me back to this notion that we have varied resources that would come to bear if, as was just talked about, Kathleen just talked about, if we compensated with different things, like the quality of the work and the quality of the satisfaction from the work by getting better communication tools and other things.
Thank you. Interesting. Bringing back and holding on to the things that we value most, particularly the patient-physician relationship. So we have Eva Powell next.
Hi, I just wanted to share something, and it's been hinted at, I think, in other areas, but what I've started thinking about is how might PCORI play a role in bringing the research infrastructure to what I'm going to refer to as a maker movement. And I don't mean that in the way that it's perhaps been used in more recent times, but what I'm referring to is essentially the community-based efforts to take care of each other because they have been left out of the traditional healthcare system. And how might we bring research to those efforts to understand what they're doing that actually does work because it's being delivered in community, and what might benefit from enhancement or more rigorous research or an infusion of evidence that's more clinically sound. And an example I'll use is I'm part of a project funded by RWJ that's focused on maternal health and with a very specific focus on equity. And in a conversation a couple of weeks ago, we got into this tension between having care that's delivered by non-clinical providers and the consumer movement to really advance those, both in terms of incorporation into care delivery, but also payment. And that payment then becomes a means of increasing economic opportunity for certain communities in the form of doulas particularly, and holding that good thing in tension with the need for providers and insurers to be certain that they are paying for and delivering care that is sound, that's safe, that puts the patient first. How do you resolve those two? And I don't have an answer to the question, but it strikes me as a place that is really that for which PCORI is very well positioned to start answering those questions. And so I guess it is essentially bringing PCORI's research infrastructure to non-clinical roles But how do we do that without kind of co-opting them to become something that then is less effective because they become part of the system, if you will? So I too have been very wordy, but that's a particular question we're faced with, and I know that there are probably others that are of similar nature in other areas.
Yeah, so thanks for those comments. I see that as connecting the healthcare system with our other sectors that have been mentioned, and how we can do that better and have people work together. So let's go next to Hal Luck.
Hi, thank you, and I apologize. I was not able to be at all involved yesterday, but just listening to these great summaries, I started wondering whether, thinking really out of the box, the notion of building back better, melding that with PCORI, and how one makes fundamental change. One of the options that I think might be explored is loan forgiveness for groups of people, physicians, organizations, etc., that essentially decide to do things very differently, that make that transition from a transactional-based healthcare delivery system to something very different. And in essence, the federal government says, we'll buy up your student debt if you do that. And to allow various organizations to try to do this and build it into some sort of a research design with PCORI involvement.
Interesting. That's what we want, is some out of the box, blue sky ideas. So thanks for that. Do we have any other comments? Okay. Not seeing any. I'm going to do one thing before we close, and what we'd like to do is, I'd like to ask you kind of a magic wand question, and it goes like this: if you could identify one challenge or priority that would enable people to achieve their best health, what would it be? So one challenge or priority that would enable people to achieve their best health. And what I like to do is let's see, everyone go by. Let's see if we can go around. If you raise your hand to offer a priority, just one priority from each of you. Anyone want to start? Yeah, Gwen, Derry.
Myself. Hi. So I guess it seems very obvious, but I don't think that it's always, I just can't emphasize it enough, is that the one priority to help people achieve health is to prioritize health over healthcare.
Okay, thank you. Eric Gasco. Eric.
I'm Eric Gasco with the National Health Council. I would say leveraging technology and incentivizing providers to co-develop individualized care plans for their patients.
Thank you, Eric. Others, please step forward. Certainly you have an opinion.
Neil, it's Sharon Levine.
Okay, Sharon, go ahead.
Yeah, so if I had a magic wand, I I would require at the federal, state, and community level that every policy put forward as an explicit articulation of the impact on health of the proposed policy, whether it be tax policy or banking policy or trade policy, that there be a requirement that the impact on the health of the people in this country or state or community be part of the consideration in terms of making decisions about policy.
Thank you. So Hal, look, you're back.
I would offer a friendly amendment to Sharon's great proposal, which is that one do that assessment with a very clear equity lens. And in fact, positively weighting improvements for those people whose health is worse than others. And you're looking for greater improvement and maybe making things a little worse for some of us. Okay.
So the people who have the most need. Interesting.
You got it. Yeah.
Greatest distance to travel to health.
Okay, Patrick Gee.
I would charge people on a daily basis to read the Universal Declaration that was written and presented by the United Nations on Human Rights.
Okay. So disseminate that document. Okay. Thank you. Peter Emby.
So I was struggling to say something other than universal healthcare. Instead, I'm going to focus in on what I think that really would get us in an ideal state, which is a lot of what we've been talking about, really being person-centered, truly transform with a magic wand, transforming the system to be truly person-centered so that everyone has access to good preventive care and when they do get sick, to excellent health care, and that it's organized and accessible in a way that works for them.
Okay. Let's go to Beverly Johnson.
Thank you. I would say to reorient our healthcare system and the system of research to build on individual and family strengths, not on deficits, so that it changes the way we interact. And I would meld that into technology. And if I can wave the wand twice, I would link citizen engagement, patient and family partnerships with the public health community and statewide assessments, so that they are part of implementation and evaluation of that work at the community and state level. Thank you.
Thank you. All healthcare is local. Kathleen Blake.
So I'm based in New Mexico, and maybe it's a convenience sample, but our legislature right now is considering a bill that will require of high school graduates that they have a course in financial literacy. And the notion there is that that will help people plan their financial, for their financial well-being for many years to come. So my magic wand would be that we would have something similar as we used to have for civics, that really establishes a level of understanding, or we might say of health literacy. So perhaps we can have the forthcoming generations be in a position where they can truly be activated for the purposes of their own health and that of their families.
That's real empowerment. Okay, thank you. Others, we still haven't heard from a number of other folks out there.
All right, Neil, I'll jump in. I think my magic wand would be, it's more of a concept, but sort of where we advance health in ways that seamlessly integrate into just our regular activities of life. And so we'll often call this sort of like, the structured environment, or, when I'm doing my usual life things online, shopping online, that sort of my health and the way that I should go about supporting and advancing my health is just baked into those. So health doesn't become a separate set of activities that happen like in a healthcare system or with a device that's only meant for me to manage my one health condition. I want to see that sort of seamless integration with my usual daily activities, rather than pulling out health and treating it as something separate that needs its own sort of activities and interventions and technologies.
Okay, so weaving health into the fabric of what we do every day in our lives. Great, thank you.
And if I can jump in to add to Julia and also Sharon and Hal's comments, I think that part of the health in all policies that I'd really like to see will actually actively get the friction out of the system for individuals who want to pursue health. I think so often, we think about an activity or an intervention, particularly at a system or a bureaucratic level. And sometimes actually what we need to do is take the barriers away. So I also want us to look at, what we're really doing now that we could simplify and minimize to help also sort of achieve what Eva was talking about in terms of facilitating the maker movement and the kinds of things that individuals are already doing to pursue their health or what they really want.
Thank you, Eric. Let's hear from others we haven't heard from. Caroline.
Hi. Since I've got a magic wand, I think the two things at two different levels. I think for me, the first one is we create an economic system where everybody has an ability to be have a living wage and access to excellent schools, regardless of what neighborhoods they live in, and the color of their skin, etc. I think coming back to earth a little bit, we have, I think value is the key here. I think we have to keep moving to a place where all parts of the healthcare system are paid to generate health and health equity. And that's what, that's I think the way we're gonna help get to a place that my magic wand would take us to otherwise.
Thank you for that utopian idea. So others, we have a few more minutes to get your thought about where we should go in. Esther.
All right, hi, trying to get on video here. If I could wave a magic wand, would envision a healthcare system where anyone can participate in research, where our information, whether it's passive or active, can really be used for the benefit of health for all. And then we have this ecosystem where each component is really built toward the needs of the patient, so by the patient and for the patient.
Thank you. Bringing all data to improvement of health. Brian.
Dr. Poe?
Brian, do you have a?
I do. So this is going to sound like a broken record to the people who are in my group, but I'll repeat it anyway. So we know that half of Americans' access to healthcare is going to depend on decisions made by their employer's HR benefits team, advised by benefits consultants. And we know that those interests sometimes are not durable. This tends to be a rotating cast as people go from one company to the next. So, you know, if it's a magic wand, first you'd wave a magic wand to get yourself a time machine. And short of that, I'm going to look for something more prosaic, which is find some way to align the durable interests of the business community, which is larger than just the role of that person in that benefits capacity for this next quarter or this next year. Find a way to align their needs for healthy, high-performing workers going forward so that they can stop thinking about taking care of the illness of their workforce now and start thinking about the health of the workforce they're going to be hiring a generation from now. I don't have an answer to that, but it's a magic wand, so why not?
Thank you. Okay, well, thank everyone for those comments. That is wonderful. And I think we've had a really wonderful 2 days of thinking blue sky. We've got a lot of blue sky ideas down. I think this will be enormously helpful in helping PCORI think about a path forward to make their activities have the most impact nationally. So I'm going to turn the podium back over to Dr. McGinnis to help close us out.
Well, thank you very much, Neil. I want to first and foremost say thanks so much to you for your masterful job at chairing and facilitating our conversations today. So thank you very much. And I wanted to get that in because I knew you have to leave shortly. And now I'd like to also turn it over to my colleague, Sharon Levine, Vice Chair of the Board of Governors of the Patient-Centered Outcomes Research Institute, for comments, and then I'll come back for a couple of minutes at the very end. Sharon, thank you for this partnership, which has been extremely exciting and I hope productive for the Institute.
Thanks so much, Mike. And on behalf of the Board of Governors of PCORI, I want to express my profound thanks to everyone who committed time to participate in the last 2 days. This has been an incredibly valuable meeting, and the presenters, the panelists, the facilitators, and the attendees, participation is so appreciated. Particular thanks to Dr. Neil Powell for his great facilitation. And again, everyone's busy, and I realize that 2 days of time is a critical commitment. And PCORI is tremendously thankful, and thankful to you, Mike, for your willingness to commit the National Academy to participating and sharing with us in this journey. PCORI looked at the opportunity that was presented by our reauthorization to make good on the substantial investment that both public and private dollars have made in PCORI's standing up PCORI. And our feeling that as we look toward the next 10 years, our goal is really to have impact, and impact through contracting for and conducting research that matters to patients and stakeholders, And that matters because it's used in the service of enabling people to achieve health. I was so struck today by the convergence among all 4 breakout groups of the themes that were expressed. The goal is health, that there is credible interdependence among the topics and among the various silos and sectors, not only in healthcare, but in all of the services that we depend upon as citizens and inhabitants of this country. The fact that there's cross-sectional ownership of health and that cross-sectoral ownership, and that, as I said before, health is part of everything we do. And to Julia's comment, removing the obstacles to health in the system will enable people to achieve the health they aspire to. And finally, value. The need, the opportunity, and the challenge of defining what it means, creating workable measures of value. If we agree that the goal is health, then defining and having accurate and adequate measures of value along the path to health is going to be incredibly important. So again, thanks to everyone who participated, and turn it back to you, Mike.
Thank you, Sharon. I'll be brief, but I do have a couple of things I want to say, because this was so rich and so exciting in many ways as we look to this critical juncture in our nation's future and our nation's health future. Starting with the title of the session, Priorities on the Health Horizon, you can take that notion as either a question of prediction of what's on the horizon or of prescription of what should be on the horizon. It's very clear from the course of this conversation that we were not trying to guess what might be on the horizon, but that we were prescribing the sorts of things that need to be on the horizon. And we started off yesterday with 4 very broad domains in that respect, and we had brilliant presentations on the 4 domains of value and social and environmental factors and technology and infrastructure that provided incredibly rich material for the breakout sessions to draw from. And they rose to the occasion quite clearly. We heard some very important observations and charges, if you will, from each of the breakout sessions. In the value group, we heard about the need for a complete paradigm shift in the way we think about value, that value is a public health emergency in many ways. What an interesting term. And that was brought home very strongly by our social and environmental group, which indicated quite clearly that the only way we're going to deal with factors that are threatening equity, that are threatening the continuity of care, that force us into episodic perspectives, short-term perspectives, are the way relate to the way our value system is structured. And so if we're going to achieve the kind of fundamental changes in the social and environmental arena that are necessary, we need pretty fundamental health system change, along with a variety of other changes, obviously, as well. We heard the same thing, a similar theme in the technology, and I would say that technology/regulatory system discussion, in which there was a clarion call for the system which is open and integrating and allows this the patient to be, in fact, the individual to be, in fact, at the core of the system, as opposed to, in many cases, tangential to the way things operate. And then from the infrastructure group, it was very clear that whether we're talking about social infrastructure or financial infrastructure or physical infrastructure, there have to be substantial changes if we're going to have infrastructure which is conducive to the value and social and environmental and technical changes that have been identified and prescribed, if you will, in the course of our conversation. So in looking back, for me, there were two overarching common themes throughout all the discussions. One, in each of these domains, these big, broad, deep domains, it's time to do a different thing. And that was what we heard at the very start of the day yesterday and what we heard throughout the course of the entire set of conversations. We need to do a different thing in each of the domains of value, social and environmental factors, technology and regulatory systems, and in infrastructure. And the second common theme, and we had some interesting and important hints and some very constructive suggestions about how we can do different things in each of those areas. The second common theme that I heard very clearly, and I know that many of us did, is that PCORI, with its mandate to anchor discovery on people and continuous learning, and to facilitate the development of the infrastructure necessary to ensure that their mandate is fulfilled, has a very strategic role. And there is, in some ways, no other organization that has as clear a mandate to engage these issues in a cross-sectional fashion, in a strategic fashion. It's clearly, PCORI is not without limits of its resources, as is the case with every organization, but they have a strategic mandate to really make a difference. So we are so grateful to have been partnered with PCORI and with all of you in this effort. And I'd like, in that respect, to close out our conversation with a very deep note of thanks and gratitude to every one of the presenters, the reactors, the facilitators, the reporters. I've already mentioned Neil Poe and the planning team involved in this from PCORI. We had Jean Slutsky and Kat Jackstedt and Laura Lyman Rodriguez from the National Academy of Medicine. In addition to Ariana, we had Mike Cocciola, Asia Williams, Anna Cupido, Peek Sen Chow, and Ayadola Nishe. And I have to say, even though she is last, she is first and foremost in terms of the energy that and creativity and spirit that she brought to every aspect of this work. Sarah Green. It's been an extraordinary meeting that has set an extraordinary obligation to each of us to take full advantage of what we've heard. And we in the National Academy of Medicine want to make sure that you know that you have an open door to follow up with us on suggestions that you have about ways in which we can help make the right thing happen a little easier. And so again, with thanks to all of those involved, both for your contribution over the last couple of days and the contributions that you'll continue to make into the future. And with ultimate gratitude, of course, to our partner, the Patient-Centered Outcomes Research Institute. We look forward to working with you in the future. To be continued. Meanwhile, thank you, be well, and stay safe. Enjoy.